So we're going to shift gears. We're going to stay in the left atrium, but we're going to move to left atrial appendage closure as opposed to mitral valve therapies. And Saibal, who's become one of the world's experts in this field, is going to introduce the technology and some of the clinical outcomes.
Once again, Marty, Sushil, and Srinivas, thank you very much for having this meeting and inviting me. And this is a topic which I think even Marty agrees is actually one of the new structural heart disease interventions after TAVI, which will probably become important. So we're going to review the data, a few things about the new devices and the results. So everybody has recognized that thrombus arising in the left atrial appendage is the major cause of stroke in patients with AFib. And closing the atrial appendage rather than long-term anticoagulant therapy is an option to prevent stroke in AFib patients. Recent studies have been completed or are ongoing using different devices and different approaches to actually support this hypothesis. If you divide the types of LA occlusion devices, you can categorize them in two groups. The endovascular approach, which is actually occluding the appendage from inside. You have the Watchman device, the Amplatzer cardiac plug, and the wave press device. These are some three, and there's several others going to be developed. And then you have the epicardial approach, which is a very fascinating, interesting technology where you basically guillotine the atrial appendage. What you try to do is you try to put a gooseneck snare around the neck of the appendage and then tighten it up through a transpericardial approach, which I'm going to show you slides later. So the Watchman data seems to have most of the clinical data. It's basically a nitinol frame covered with fabric where you advance the sheath into the left atrium. You make sure that the device, the appendage is a suitable size. You take a device which is 20% larger than the maximum orifice, and then you deploy it by just retracting the sheath, and you can tug at it, and once you see it's fine, you can release it. The advantage is this gets covered with tissue over 45 days to 90 days, and then you can take them off Coumadin, and usually by 6 months to 1 year, they're off Coumadin. The procedure is done in the cath lab. You can see that's the pigtail angiogram showing you atrial appendage, and that's actually the device being deployed. We can see they're retracting the sheath very gently. It's very important not to push it forward. And then you can see over here we're doing a tug test to make sure it's stable inside the appendage, and then finally you do a contrast angiogram to show that it's completely obliterated the appendage. The data is over 2,000 patients. The beautiful part about this is that they have 2,000 patients in clinical trials, either completed or almost completed. The first part of the data is a series of trials with the PROTECT-AF trial, the pilot study, and the continuous access. And the second part is the Prevail trial. So we start about the PROTECT-AF trial. This is the first randomized trial to actually compare medical therapy versus closure of atrial appendage to actually test the hypothesis that actually closing the appendage does work equivalent to medical therapy. And so the idea was an endpoint, which is endpoint of stroke, cardiovascular death, of embolization, and then there was a safety endpoint of device embolization, bleeding, and other complications. And you can see over here, if you collect the 1,500 patient year now collected over 3 to 4 years, the event rate in the Watchman device is 3%, and the event rate in the control arm is 4.3%. And therefore there was almost a 30% reduction in event rates with the device group compared to the medical arm group. And this achieved a value of non-inferiority, but was not enough for superiority. So if you had a larger number for longer follow-up, this may have achieved superiority value too. And this shows you the efficacy in a graphical form, the same slide. But what is impressive to me is that this actually tells you that the concept is correct. Because you can see over here, at around 6 months, most of these patients are off Coumadin. And the control arm, as you can see, continues to diverge from the device group arm, telling you that the control arm continues to have some events. But these events are usually hemorrhagic in nature, whereas the control arm is not showing too many events, telling you that the concept is correct. But however, the price that we paid was the procedure itself, and that is the safety complications of the device. And these were, as you can see, higher with the device group compared to the medical arm group. And the main complications was pericardial effusions and tamponades a very few percentages of periprocedural strokes and some embolization. So these are the three critical points. And so the AF protected alpha demonstrated that we were non-inferior to Coumadin as far as prevention of stroke was concerned, but there were definite safety issues about the procedure itself. And this led to the analysis of the continuous access registry. And what was done in the continuous access registry is that we actually removed 50% of the sites which had done less than 15 cases. And only the sites which had done more than 15 were a part of the continuous access. So in other words, it took people who had a little bit more experience. And you can see over here, with experience, with the same device and the same procedure, the implant success goes up from 89 to 95%, and the discontinuation of Coumadin goes up from 86 to 95%. So the success rate and the implant success has gone up. And then if you look at the safety events, which is most important, you can see that the procedure-related strokes has dropped to 0 in the next 500 patients, and the pericardial effusions from about 5 to 6% dropping to 2%. So that means there's still a small incidence of pericardial effusion, and I think that's related to somewhat to the design as well as the procedure itself, which will probably never go away, but it's going to be a low. But the interesting part is the procedure-related strokes are going to 0, which tells you this is related to the way we desheath or treat the sheaths inside the left atrium, not the device itself. The other question that people have asked is, what if you have a small gap around the device and there's some leak? And we actually analyzed our data recently, and we took all patients who had patients with less than 5 millimeter leaks, because anything greater than 5 millimeters was considered to be not effective. And if we divided them into different small groups, we noticed that it didn't matter whether you actually had any leak at all. If you had a leak less than 5 millimeter, whether it was none or small, there was no real incidence of differences of endpoints. So if you basically had a gap less than 5 millimeters, it was almost as good as if you didn't have a leak at all. The next part is the use of the LA appendage occlusion device in people completely contraindicated Coumadin, because this is a group of patients which really needs to be treated. And this was a registry in Europe where they took patients who were completely contraindicated for Coumadin, and they were treated with the device and were given aspirin and Plavix. Plavix for 6 months, aspirin for life. And the average CHAD score was 2.8, 150 patients, and all were followed equally well. And you can see over here the results demonstrates the safety, efficacy. You can see that this group, the estimated stroke rate was considered to be about 7.3%, and actually see that the actual stroke rate was only 1.7%. And what you notice is that this is, to me, a very exciting period, and Marty, you'd probably think about it, agree with this, that this is the same number that we achieved in the PROTECT-AF trial, about 2.2%. So we can see that that's the rate of stroke that you have with patients on Coumadin therapy. So if we can achieve a value consistently in several studies with the same number around ranging between 1.8 to 2.5%, we know that the concept is probably correct. So what is the regulatory update? The regulatory update was that the FDA panel voted 7-5 in favor of the device approval. In March 2010, the FDA announced non-approval and requested further studies, basically having some concerns with the safety issues. The CAP registry showed some safety, and then in November 2010, a new study was started with people with high-risk growers, and that has also been completed. So that was the Prevail Study. And in the Prevail Study, what was done is that patients with the same inclusion criteria, the only difference is they had to have a higher risk for stroke. They had to have a CHAD score of 2 or more. And the good news is that in June 2030, 400 patients have been completed enrollment, and we hope by December the data will be available about this trial. And so we hope that if the data is consistent with the previous 2 studies, with slight improvements of safety, it should get approved. So we conclude from that the summary that the PROTECT-AF trial was the largest clinical trial that confirmed the hypothesis that LA closure is non-inferior to Coumadin in the prevention of stroke for AF patients. The CAP registry demonstrated this increase in the safety of the procedure with experience, and the small peri-device residual leak is common but does not increase the risk of stroke. And the ASAP registry showed a reduction of expected ischemic stroke patients with patients contraindicated with Coumadin. So even patients with contraindication of Coumadin and given a bridge of just aspirin Plavix, it probably does work. And finally, the Prevail study is the landmark confirmatory study evaluating the role of Watchman device in patients with a higher risk for stroke, that means CHAD score of 2 or more. We hope we shall prevail. The next device is the Amplatzer cardiac plug, and there are actually more than 3,000 implants with the Amplatzer cardiac plug. In the US, it is still investigation and a pilot study has been completed. But watch the device characteristic. It has some very unique features. It's got a lobe and a disc. And you can see this device compared to the Watchman device is shallower. So if you have a large appendage, which is very shallow, this device is a superior device. And this is a good thing. It comes in multiple sizes. And the principle is that you introduce the lobe and then you have the disc that actually closes the ostium of the appendage. And here's an example of 3D echo showing you the appendage. That is the lobe. That's the disc completely closing off the ostium. That's the 3D view of the mouth. And that's completely shut off over here. Usually it's away from the mitral valve, so it doesn't usually impinge on the mitral valve. They've had CE mark approval since 2008. There were 204 patients enrolled in a 20-country European registry, but realistically in the market it's available in Asia, it's available actually now in India, I understand, and available, and we're going to do a procedure tomorrow. We're actually going to show an ACP case tomorrow. And there's a new prospective randomized study in the US about to start of 1,300 patients. And this is the data from that 204 patient study. You can see over here the success rate was very high. It was 96%. Their safety events was 5.4%. There's a slight increased risk of embolization. It's about 1.5 to 2%, but the pericardial effusion rate is low. So I think there are some issues about the anchoring of this device. And finally, a few words about the lariat device, which is basically a principle of a transpericardial approach of applying a suture around the neck of the appendage. So it's a very interesting technology. So we're going to show you the technique and what you do. And what the principle is that you first do a transeptal puncture, do an angiogram, and then you advance a wire which has got a magnetic tip to it in the tip of the appendage. And then you do a transpericardial dry tap. You advance a 13-French sheath, and through it you advance another wire with a magnetic tip, and then it finds the tip and attaches itself because it's magnetic. So basically you form a ring, and then over that, and then you include a balloon, then over that you advance a gooseneck, sort of a snare, which is the lariat device. It basically cinches around the appendage, and then once it's very tight, you release the balloon and come out, and this you can confirm by echo. So look at over here, that's the appendage. That's the occlusion balloon and the wire. That's after it's completely tightened, and this is what it looks like at follow-up. See, the appendage is completely squeezed. Now, the advantage, this is obviously looks a little bit more tricky that you have a transpericardial approach and an endovascular approach, so it takes two. You have a risk of pericardial effusion, but the two important things fundamentally which makes it interesting is, one, you don't have a foreign body left inside the heart, and so potentially you'll have less thrombus inside the heart, and you probably can take off these people off Coumadin or any dual antiplatelet therapy earlier than a endovascular approach. And second is, since you actually have a pericardial catheter in place, you can't have a patient who suffers from a tamponade because you already have a pericardial catheter. The disadvantage, of course, is pain, and case selection is more important. Here you can see over here, a lot depends on the anatomy of the appendage. So if the appendage is very wide or the appendage is turned around posteriorly, you won't be able to lasso the appendage. So you have to do a CT scan of the appendage, understand the orientation of the appendage, make sure that the appendage is not 40 millimeters wide, and then this procedure can work. So realistically, you can see over here, if you take about 10 cases, probably 7 will be eligible, about 3 or 4 will not be. So we can summarize by saying that percutaneous closure of the left atrial appendage is an effective alternative to long-term anticoagulation. There are clearly early safety issues, but no long-term issues. And even after now following patients for 5 years, I've never seen a long-term issue with this device. The ongoing studies with more clinical experience will hopefully confirm this hypothesis and also increase the safety. There are novel devices and approaches which are in development, hopefully increasing the safety and efficacy of this procedure. So what is the role of LA appendage closure in the era of these new antithrombotic? Because people are going to say that now we have these 3 new drugs, and why do we need to have LA appendage closure, especially when they don't have to be concomitant? But there are 3 categories of people where it clearly is useful. One is patients like who have coronary disease and are already on dual antiplatelet therapy and now have AFib. If you add a 3rd drug, the bleeding risk goes up. Second is patients who are intolerant to antithrombotic therapy. There are a lot of people who cannot take long-term anticoagulants for side effects. And finally, patients who do have a history of a major bleed, either intra-abdominal or IC, I think the risk of a second bleed is much higher. This is a group of patients where LA appendage will be a superior technique than just antithrombotic therapy. Thank you very much.